On behalf of the American Heart Association, I would like to welcome you to today's webinar, Addressing Recurrent Pericarditis, a Multidisciplinary Approach to Care. My name is Bianca Presley, and I'm a Senior Program Manager at the American Heart Association. Today's educational content is made possible in part by a grant from Conixa Pharmaceuticals. I'd like to begin by going over a few items so you know how to participate in today's event. If you would like a copy of today's presentation, you can download a PDF from the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that doesn't work, please review the system requirements or contact the GoToWebinar customer service team using the system requirements link in your confirmation and reminder emails. At the conclusion of today's presentation, you will receive a link to access today's recording and an invitation to complete our feedback survey. We welcome you to submit text questions for our presenters at any time in the questions pane of the control panel. We will collect your questions and address them during the Q&A session at the end of today's presentation. In today's webinar, we will be discussing recurrent pericarditis through the lens of team-based approaches to care. To better understand the context of the models that will be presented today during our webinar, we would like to provide you with a brief background on the need for this webinar and the initiative overall. Pericarditis is inflammation of the pericardium, a sac-like organ with two thin layers of tissue that surround the heart. Pericarditis can be acute, meaning it happens suddenly and typically doesn't last long, or recurrent, meaning symptoms occur again after an acute episode has been resolved. Recurrent pericarditis can be difficult to treat effectively, and given the ambiguity in assessment, diagnosis, and treatment of recurrent pericarditis, there are significant opportunities for improvement. The Addressing Recurrent Pericarditis initiative aims to address the gaps and barriers in patient care, understand the patient pathway, and develop and disseminate best practices nationally with regards to improving identification and referral to treatment for patients with recurrent pericarditis. For more information on the latest and for upcoming event information, resources on the topic, and a map of participating sites, please visit heart.org and search Addressing Recurrent Pericarditis. Please note, the recommendations and opinions presented by our guests may not officially represent the position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA or ASA. The AHA and ASA does not endorse any product or device. Now, it is my pleasure to introduce our speakers and moderators for today's webinar. Brief bios of each speaker and moderator is included in the handout section of the participant control panel, as well as today's presentation. Another reminder, this webinar will begin with model shares from 3 clinical systems, followed by a panel discussion to further explore each system of care and approaches to recurrent pericarditis from the lens of multidisciplinary teams. Our moderator will pose audience questions during the discussion as time allows. Dr. Mohammed Al-Kazaz is the Section Chief of General Cardiology at Bloom Cardiovascular Institute at Northwestern in Chicago and an Assistant Professor of Medicine at the Feinberg School of Medicine, Northwestern University. He is also the Medical Director of Pericardial Disease Program. Dr. Jessica Carey has several years of experience as a clinical pharmacist practicing in acute care cardiovascular medicine at the University of Utah Health. She is now currently a pharmacist in the cardiovascular medicine clinic at the University of Utah Health and serves as the assistant clinical faculty member for the University of Utah College of Pharmacy. Mary Heine is a board-certified nurse practitioner and the pericardial coordinator at Cleveland Clinic's Pericardial Disease Center, where she plays a central role in the multidisciplinary care of patients with complex pericardial conditions. Our moderator, Dr. Alan Klein, is currently a professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western University. the director of the Center for the Diagnosis and Treatment of Pericardial Disease, and a staff cardiologist in the section of Cardiovascular Imaging Department of Cardiovascular Medicine, Heart, Vascular, and Thoracic Institute. He has been the director of the Cleveland Clinic's Valve Disease Structural Intervention and Imaging Summit courses for the last 27 years. And last but not least, we have Dr. Tom Wang, who is a staff cardiologist in the section of cardiovascular imaging of the Department of Cardiovascular Medicine, Heart, Vascular, and Thoracic Institute of Cleveland Clinic, as well as a co-director of the Pericardial Disease Center and assistant professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. Thank you, Dr. Klein, once again for moderating today's webinar. The floor is now yours.
Okay, welcome everybody out there. We have an excellent panel, an all-star panel, and we'll be addressing recurrent pericarditis. And I'm going to call on Dr. Al-Kazaz from Northwestern to hit it off. Mohammed.
Thank you so much, Dr. Klein, and thank you for the AHA for this invite and for everyone for joining us. So the main purpose of this webinar is to discuss the multidisciplinary approach to pericardial disease and our experience in Northwestern. And I'll start by saying it's a very collaborative field, that we're lucky that these centers of excellence for pericardial disease work closely with each other. So when we first historically started in Northwestern, I reached out to Dr. Klein 3-4 years ago, and he was more than generous and shared many of his experiences. We built our own model, but we took a lot from his advice and we learned a ton. Obviously, his contribution to the field are fantastic. Next slide. So this is our institution, the Bloom Cardiovascular Institution in Northwestern. It takes a village to take care of those patients with pericarditis. We work closely with our cardiac surgeons across many diseases, whether it be valve disease or pericardial disease. And in this time and age, the overlap between imaging, therapeutics, medically and surgically, as well as the research endeavors in the pericardial space, requires truly a center of excellence. Next slide. We are located obviously in the city of Chicago, whom I love, and Northwestern is the picture to the right. Next slide. Our team has a core faculty that consists, that's the first seed kind of when we started the program. It was initially by myself, then we recruited for many good reasons faculty from different places, and Dr. Douglas Johnston, who's our chief of cardiac surgery, is an expert pericardial surgeon. Dr. Paul Kremer, who came to us from the Cleveland Clinic, is an expert also in pericardial disease, and this is the core faculty of pericardial management that not only prescribe medications, but have the imaging expertise that make sure we have the right diagnosis for the right patient and the right time and offer the right therapy, whether in the setting of a center of care or clinical trials or otherwise. Next slide. And it's important to identify those main players because around them we will build the whole village. And there is the clinical arm where we have a nurse coordinator that has the intake, that does the intake for the patient, whether they're internally referred or externally referred, whether they're coming through from another physician or self-referral. And thus, nurse coordinator makes sure we have all the needed information to make the visit as comprehensive as possible and as efficient as possible to push the care fast and get the right patient to the right doctor at the right time. And within our team, once the patient makes it to the door and sees us, we have a nurse clinician that helps us manage those patients, manage their telecommunication with us, their phone calls, and we have a central role for our APPs and advanced practice providers, their PAs or MPs, who help us follow those patients long term because of the needs what they have with titration of medications and follow up. Another part of our team that we recruit is PharmD and a Pharm Tech that helps us with the prior authorizations or drug interactions or different things on the inpatient and outpatient side, and they have built expertise in pericardial disease per se. In addition to that, we have cardiologists who are clinically seeing the patient that I mentioned myself, Dr. Kremer, and we have our self-imaging expertise, but we have improved our imaging protocols to make sure that we capture the appropriate pericardial diseases on echo, whether the patient was ordered for it from pericardial standpoint or just incidentally found to have, let's say, constriction. Similarly for the cardiac MRI protocol. And we have worked closely with our interventional cardiology team to build hemodynamic protocols and for, let's say, cases of constriction, though in this time and age, obviously, echocardiography has negated the need for those for many cases. Another important arm, in addition to the clinical arm, is the research arm. And we have the clinical trials unit here in Northwestern that have provided support for us to help as we build our practice to launch couple clinical trials, internal registry, and obviously we're part of national registries as well. And it's a heavy lift from them, whether recruiting patients, consenting them, and following up on them in phase 2A trials or 3 trials. And obviously, I'd be remiss if I don't mention the surgical arm led by Dr. Johnston, or even by Dr. Sam Smith from the thoracic surgery team for pericardial windows if needed. And they have similar structure in terms of APP, nurse clinicians, and we work closely with our anesthesia and ICU teams and pathology to make sure we provide the appropriate care and diagnostics. Next slide. And the village is even bigger than the core. So we have the core faculty, and we have built people within the cardiovascular institute around them, whether in the clinical, surgical, or research arms. But sometimes when we have concerns that the patient etiology for pericarditis is beyond idiopathic or autoinflammatory, and we think that, let's say, undiagnosed autoimmune disease, whether lupus or not, and we have built our own expertise kind of clinically trying to diagnose these issues, but we want to make sure that they see the right specialists, and we have built a template that we can get them seen and minimize the number of visits, especially for patients who are out of town. And we had obviously some cases of fungal or TB pericarditis that we need management and input from infectious disease doctors. And in some cases, especially with advanced constriction where liver cirrhosis or portal hypertension might be involved, or coexisting liver disease, we involve our liver team, liver medicine. Next slide. Who are we targeting? So obviously, as we build our team, we want to make sure that we use those spots for the right patients. So we build our referral network within the Chicagoland first, and obviously within our state and the states close by to us, whether Indiana, Wisconsin, and so on. And we want to target patients, especially who are having recurrent pericarditis, especially resistant to colchicine as a starting point or incessant, constrictive pericarditis with their reversible or irreversible subacute or chronic, pericardial infusion, especially complicated cases, or pericardial masses. So we want to make sure we have the right patient at the right time. Next slide. And this is a high level view where the patient, whether self-referred or somewhere else, comes to us. A nurse coordinator have the intake, make sure we have the right information, discuss with our physician based on the chart review, and then we say yes, or we need this and that, and then she reaches out to the patient and discuss the next steps. And then if there is needing for repeat imaging or testing, then we schedule that and we try to clump it as one visit for those patients. Next slide. This is a little bit more detailed, but had the same concept, where the nurse coordinator is the backbone of this whole program. And if the patient has a clear indication for us, because sometimes patients per se are like kind of in the wrong direction, and we direct them within our system to the right spot within cardiology. But if they do need to see us in the pericardial clinic, we complete the testing and get it all done same day. And if we feel upon review with the MD that there is a need for surgical opinion same day, we will try to arrange for that clumped all together. Next slide. It improves the patient experience and improves the chances of us directing them in the right direction, whether it be a clinical trial, IL-1 blockers, or surgical interventions. So I touched base on that, but the basic of it, the nurse coordinator becomes pretty much, she knows how to manage pericarditis, and she knows what we need diagnostically and therapeutically and what they have got done, and which she kind of can tell which direction they're going, and whether it is clinical arm or surgical arm. Next slide. I could not emphasize more that even though we have made tremendous advances in the field of pericardial disease, there's more to come, and there are more options, and whether therapeutically, diagnostically, on medical and surgical sides. And having infrastructure and services to provide cardiovascular research is really, really important. And I could not thank enough our clinical trials unit, which we started with a smaller program, and now we have multiple trials and hopefully to grow even more. So the research is a big part as we push the envelope in this field, and this emphasizes the need for truly centers of excellence in pericardial disease. Next slide. We arrange for follow-up for those patients via telehealth, and the APP is central in all these things, whether for lab or otherwise, and similarly in the research arms. And then we have MD follow-up either electronically or in person based on the testing, and then maybe annually with imaging. Next slide. In summary, Centers of Excellence for Pericardial Disease are our cornerstone for providing care for those complicated patients. And they have advances in therapeutic and diagnostics, and it truly requires a multidisciplinary approach, and there's growth in all ends. And this field is very collaborative, and again, I'm thankful for all the mentors that helped us get where we are. And thank you for the AHA for the invite.
Thanks, Dr. Al-Kazaz. Excellent presentation. I'm glad I gave grand rounds in Northwestern. I got you going, but nice to see how well organized you are. And developing the pericardial program.
Thank you.
Thank you so much. The next speaker is Jessica Carey from Utah, and she's a pharmacist. Jessica.
Thank you for the introduction. I'm a pharmacist. I work in the cardiovascular medicine clinic, but I'll talk about my role in the pericarditis clinic. Next slide. So at the University of Utah Health, we have a pretty robust faculty and staff. We're one of Utah's largest employers, and we are the only university healthcare system within Utah. We provide care for people in rural areas of Utah, as well as surrounding states, and we have a fairly robust medical academics campus. Within our cardiovascular center, specifically general cardiology, we have about 25 general cardiology providers seeing patients at 13 different locations across the valley. Last year, we roughly saw 17,000 patients just within general cardiology. And I just mentioned that because that's where most of our pericarditis referrals will come from. Next slide. So getting into the meat of the presentation, or our care pathway, our inpatient referrals or clinic referrals look pretty similar. And sometimes this comes from different groups like internal medicine, emergency department, rheumatology. So coming from anywhere, we've generally educated these other specialties on how to complete a working diagnosis of recurrent pericarditis and how to contact us, how to assess treatments trialed and failed, and appropriate baseline imaging that might be needed or helpful for the patient. And at that point, if it's a severe case on the inpatient side, typically our recurrent pericarditis physician will be contacted. And in any event on discharge or from ending the clinic appointment, a referral will be placed to see us in clinic fairly soon. In the background, typically the physician and myself are actually notified that we have someone coming our way. This has been particularly helpful, especially with education on this process, because then I start the screening process for initiation of potential IL-1 therapy. We provide recommendation for baseline labs and other imaging that should be obtained prior to coming to see us, and also recommend a transition plan to IL-1 therapy so that when they come to see us, we're ready to go with that escalation of therapy if needed, or if prior to seeing us, they have yet another recurrence and that therapy needs to be started, we can act sooner. Also in the background, we have a specialized pharmacy technician. She actually is pretty well cardiology trained. She helps me with initial counseling with the patient and also our prior authorizations. She also helps maintain the prior authorizations so that on an annual basis, when those prior authorizations need renewal, there's no gaps in therapy, which is critical for some of these patients. Our team includes a physician assistant, myself, a pharmacist, a nurse, and a pharmacy technician. We meet monthly to review our patients and also incoming consults that are complex so that we can come up with the best treatment plan. We also talk about patients that require reassessment, duration of therapies, and follow-up, etc. Next slide. So in order to illustrate sort of our multidisciplinary process and also how it extends into a multi-specialty process, I wanted to present a case of one of our patients. So we had a 21-year-old male who had been presenting to several outside emergency departments, and each time he was diagnosed with costochondritis. He would receive short NSAID courses, short steroid courses, tramadol, but was never appropriately treated for acute pericarditis or diagnosed with that. He eventually made it to our emergency department, where an echo showed concern for pericarditis in addition to presenting symptoms and severely elevated inflammatory markers. Because of that, the referral was placed to cardiology, recurrent pericarditis team, and rheumatology. Rheumatology diagnosed him with lupus, and we initiated IL-1 therapy with rilonacept. Rheumatology was treating the patient with hydroxychloroquine, and other therapies were tapered off. Our pharmacy technician managed prior authorizations with the patient's insurance, which actually was, for this patient, proving to be very challenging. And then, of course, our nurse has been fantastic about following up on monitoring and annual vaccines and other appointments for this patient. Next slide. So I bring this case up, and because now in bold, I am showing here how many times different teams, different providers, different specialties have touched this patient. And when we first started this, not just a year and a half ago, so we're fairly new, Pericarditis Center, we started realizing how many players were involved in this. And so we have now reached out to our emergency department colleagues, internal medicine, rheumatology. We still work with our cardiothoracic surgery team, cardio-oncology, and infectious disease. All of these people have been educated about our process and how to facilitate getting patients to us in a very streamlined fashion. And so I think that in summary, what I wanted to illustrate is not only are pericarditis teams with multidisciplinary aspects required for a pericarditis center of excellence, but also education to multiple specialists involved in this sort of as extensions of colleagues on our team. Next slide. This is our team. I'm very grateful to them. We've really built this from the ground up. Dr. Wang is our fearless leader, and then myself and Dr. Ryan, Dr. Ramakrishna, and then Denise, our physician assistant. Wonderful team to work with, and we are so excited to be continuing to build our program and work with our colleagues across the nation. Next slide. Thank you for the opportunity, and look forward to the panel questions.
Jessica, that was tremendous. Nice to see a growing team, and how many touch points of all the different departments that see the patients. It's very complex before they see the right team. Okay, great. Moving along, now I'm proud to introduce the Cleveland Clinic team. Another Dr. Wang, Tom Wang, and Mary Heine, which help lead the Pericardial Center. Tom and Mary. Tom goes first.
Good afternoon, everyone. It's my privilege today to present on behalf of other staff and physicians and from Cleveland Clinic to contribute to this pericardial disease webinar. And we thank American Heart Association for this. And Mary will also be contributing to our talk today. She's our Pericardial Center coordinator. Next slide. So Cleveland Clinic has one of the largest pericardial center volumes in the world. You can see every year we see about 3,000 patients here, inpatients and outpatients. And there's been a steady increase over the last 10 years or so, with a blip in 2021 after the COVID pandemic. A quarter of our patients are new patients and a third of patients are from out of state. Next. Out of these patients, approximately 1/3 of patients have recurrent or chronic pericarditis, and their etiologies are 70% idiopathic or viral, 10% post-cardiac injury, which is definitely rising with the increased number of cardiac procedures, as well as autoimmune and neoplastic. Next. And we also do procedures in the Pericardial Center here with pericardiocentesis every second day, pericardial windows twice a week, and pericardiectomy surgery approximately once a week. Next slide. So the Pericardial Center is a large multidisciplinary center, and we have lots of members that are involved with managing these complex patients. Dr. Klein leads our Pericardial Center, but the Christine Jellis, Deborah Kwan, and myself are co-directors for the center, and there's several cardiologists with interests that see these patients as well. Our surgical directors, there's 3 main cardiac surgeons, Dr. Kopravanik, Dr. Tong, and Dr. Bunai, who performs the pericardiectomy surgeries as well as associated procedures. And Mary Heine, as I said, is our pericardial coordinator, and she will talk more about the role of advanced practice providers in managing these patients. Next slide. So as sort of world leaders in the area of pericardial disease, our center has a lot of cardiologists and expertise in this area, and we've been fortunate enough to be involved in writing consensus statements, mini guidelines, and so on for pericarditis. So this, for example, was the document that 22 international experts contributed towards international position statement published last year in pericardial disease, focusing on multimodality imaging. And this is how we practice here at the clinic with this document as a framework. So we manage patients with acute, recurrent chronic pericarditis, as well as complicated pericardial effusions, constrictive pericarditis, as well as pericardial masses. We utilize all the different imaging modalities from echo, CMR, and CT, and we have, for echo, looser, but for MRI, pretty strict criteria in terms of when you should use to evaluate patients for surveillance and for treatment guidance. Next. Here is an example of a CMR case of typical pericarditis, where you can see pericardial thickening on the black blood images, pericardial edema on the T2 stir sequence in the middle, and pericardial late gadolinium enhancement at the bottom, indicating inflammation and fibrosis, which is a fat suppressed sequence. Next. And then we give recommendations on when multimodality imaging should be utilized, is reasonable to consider or not recommended, as well as treatment. Next slide. So the medications we use in pericarditis are pretty standard. The first line medications are either high dose aspirin or NSAIDs such as high dose ibuprofen coupled with colchicine. And then we have the second line agents, which are now moving towards the anti-IL-1 agents such as rilonacept and anakinra, with the DMARDs such as prednisone in our armamentarium as well. Next. And as a result, Dr. Klein led the multi-center international study, the pivotal Rhapsody trial on rilonacept. And this has really been a paradigm shift with the management of patients. So nowadays, anti-IL-1 agents are now second-line agents that we use in treating recurrent and chronic pericarditis if they fail first-line therapy, especially for those with the inflammatory phenotype, elevated inflammatory markers, and so on, and can still be considered in patients with the non-inflammatory autoimmune type phenotypes with other rheumatological conditions alongside steroids. And pericardectomy is an important last line resource we can use for treating not just the typical constrictive pericarditis patients, but also those medically refractory inflammatory pericarditis patients, preferably at a high volume in expert centers, which has good outcomes. Next slide. And so this is like a hub and spoke model of the Pericardial Center of Excellence. We get referrals from all around in different specialties. We see them in the clinic and inpatient setting. We investigate with cardiovascular imaging as well as lab tests, which we get on the same day as the appointment. We involve the relevant subspecialties where appropriate, as well as cardiac surgery when interventions are required, and interventional cardiology when heart caths are required. And then we have a great team here, including nurses, the pericardial coordinator, as well as research fellows and research nurses to be involved in both research for clinical trials, publications of cohort studies, guidelines, conference attendance, as well as education. And this gives a good segue to Mary to talk about her section on the role of the APP.
Thank you, Dr. Wang, and I want to thank AHA and also Dr. Klein for the introduction. Yeah, if we could go to the next slide, we'll lead into more of our patient, our pathway, and highlighting the role of the APP. We do have a lot of similarities within our system with Utah and with Northwestern. So I'll highlight some of the important aspects that help us improve our patient outcomes. Like the other systems, we do have referrals from outside, self-referrals, and also internal referrals like emergency room and hospital discharges. I want to emphasize here that this is, a lot of this begins before the patient even comes to the appointment. So we get a chart review, the APP does a chart review of the patients before they come, and there's outside imaging and records that are reviewed. And we have a pericardial order set that is free for our admins to use, our RNs, our APPs, so they can go ahead and order any imaging and any labs and other tests that we need to schedule, and also schedule any outside referrals. Once this is done, the patient's appointment is made. They come through our Pericardial Center. These patients are coming from all over the country, even internationally, into our center. At that point, there's a thorough history and physical done by our pericardial specialists. they are then sent for their imaging, echo, MRI, CT, lab work. I think we want to highlight an important part is that the patient usually comes back either that same day or the following day to review the images and the labs, which I think is an important part of improving their outcomes as well as improving patient satisfaction. And so they get a very comprehensive care at our center. Once they come back and they go over the imaging, the treatment plan is then set up for the patients. And that's where the APP comes back into the role, and we go over new medications, escalation of therapy. If we're starting the biologics like rilonacept, we make sure the patient fills out that paperwork at that appointment, even if we're not going to initiate at that point in time. At least we have the paperwork, we initiate the PA. So if there is another flare and the patient wants to go ahead and escalate therapy and they are far away from us, we can go ahead and do so at any point in time. We go over any diet modifications, any exercises. Many of you know we put patients on an exercise restriction, which is it's hard for a lot of our younger patients especially to modify their exercises, keep their heart rate under 100 beats per minute before we start the rilonacept, before they're on the treatment or any other treatments for a long period of time. At this time too, we're going over side effects of the medication, how to manage their pericardial flares, and basically providing reassurance and education on these lifestyle changes. At the same time, at that point in time, we're either setting them up, if it is autoimmune, we're setting them up with rheumatology, either at that visit or maybe at the 3-month, 6-month follow-up. If they need to see cardiothoracic surgery, infectious disease, this is done at that point in time or at the follow-up appointment. They're also screened for any clinical trials that they may be eligible for at that visit. And given they meet with our research coordinator at that time for that clinical trial, and they're kept on our list if they are not eligible at some point in time. And then they do have a 3-month, usually in person or virtual, with the APP, followed by a 6-month follow-up with the pericardial specialist with any other additional imaging or any repeat imaging that's done. It's important to note also at that between the 3-month and the 6-month visit, there's a lot of communication. And this is where the APP has a big role with following up labs, tapering of medication, messaging through the portal. A lot of times through the portal, patients are messaging questions about medication side effects, abnormal labs, any pericardial flares they might be having, or if they choose, or if they didn't have escalation of therapy with an IL-1 blocker, if they're having a flare, then they can message us. And since that paperwork's already done and the labs are already done for the biologic, we've already reached out to specialty pharmacy, who helps us a lot with this process. We can go ahead and initiate the IL-1 and even when the patient's hours away from us. Go ahead, next slide. Just wanted to highlight our education process. This is a folder that every pericardial patient gets when they come into our center. It's basic info about our center, our physicians and our care team, introductions to them, and then what to expect at your appointment and what to expect after your appointment at the 3-month, the 6-month, as we treat you over the next few years. Basic info about medications, the side effects, what labs you'll need to get with those medications. And then we also highlight the follow-up care and how we're going to follow you through the next course of the patient's journey. We also have some risk stratification information, and also there's an exercise sheet that we provide for the patients, so they have some guidance about how much exercise they can do, where their heart rate needs to be. Next slide. This is an example of the exercise sheet that we highlighted. Patients really like having this because right at that stage 1, when we're escalating therapy, putting them on the IL-1, we're keeping their heart rate under 100. But we kind of tell them, as you progress, as you're on the rilonacept, we can go to stage 2, we can go to stage 3. So this is a good reassurance for the patient that they can continue with their normal lifestyle after they've been on the therapy for a few months. Next slide. And go one more forward. Just wanted to highlight the patient support that we have too, because you know, as you all know, this is a chronic disease, and it's important. You can see from, there's a Facebook page that has about 10,000, you know, we got about 10,000 members. A lot of patients get their information from there, and it's important that we as pericardial centers provide the correct resources for this patient. The Pericardial Alliance is a great resource for our patients. They're a nonprofit organization. They are very good at spreading awareness, sharing research, providing education, and providing support. They share patient stories and patient journeys. They provide a lot of resources, so it's important that we highlight them, and a lot of our referrals are coming either you know, from this Facebook or from this Pericardial Alliance as patients are sharing their stories. Just want to say the outcomes for these pericardial patients, they're improved significantly with our centers, with this multidisciplinary approach, with seeing the specialist, the physician, the APP, talking to the nurses, working with specialty pharmacy. It highlights and improves the medical and the care that the patients get at this center. Just want to thank again, next slide. This article just highlights the role, basically summarizes the role of the APP, which is also summarized in a recent article that was published, the role of the advanced practice provider in the pericardial center. Basically, this slide just summarizes how the APP screens new patients from start to finish. They're involved in the care of the patients. We're screening new patients, collecting their outside records and images. We're ordering all the appropriate tests and consults, and we're heavily involved in the management of the patient before and especially after, with the titration of medications, education in regards to the medications, the side effects, the lifestyle modifications. We are go-to between pharmacy and the physician and the patient in the initiation of biologics and the process and education with that. And it's essential to have the APP involved in the setup and the follow-up of all the labs, monitoring the labs, and really emphasizing the communication to the patient through our patient portal. Thank you.
Thanks, Tom and Mary, for a beautiful presentation. Okay, so we're going to turn over to the panel discussion. So we heard a lot of similarities between all the different centers, Chicago, Utah, and Cleveland, but there are some differences. So some of the general questions would be, for a multidisciplinary team approach, what are some of the challenges to develop this? How do we communicate within the teams and outside the teams? If you were a new site, how do you build it? And once you build it, how do you sustain it? So there's some general questions about the team approach. And maybe just go, we'll start from Mohammed, then Jessica, and then Cleveland Clinic.
Yeah, very good question. So starting a new program, obviously, we need support from leadership. So it starts by pitching the idea. And it's usually easy, or at least was easier to sell it, because there was need. And there was need in the Chicagoland area with need for pericardial center that can provide excellent care with the advances. So once you get the support from the leadership for the concept, you start small, and you're, as they say, once you open the gates, you know, it's a flood. You know, there's no lack of patients. You know, and thankfully the word gets around, and the program size increases. And with the more we have in terms of clinical demand, the support grows. We started by just a physician. Then we started after that with a nurse coordinator, and obviously the nurse clinician, the APP, then the PharmD and the Pharm Tech. And simultaneously, we're improving our imaging protocols to make sure we have high quality protocols for those patients. Subsequent to that, consolidating with our surgical colleagues their programs to offer surgical options for refractory insistent pericarditis or recurrent pericarditis or constriction. So it starts small, and with the more clinical demand, and there is, the more support you get. And then the next steps becomes, as you build the workflow of the referrals clinically, and you feel like you're at a stage where you're growing naturally and spontaneously, we allocated dedicated days for pericarditis clinic in addition to additional days during the month, where we try to have same day testing as the same visit, whether be it MRI, echo, and see the appropriate consultants in the same day. And that has been successful, especially for people coming out of town. So we started small, local, and then we're growing more and more to a national level, hopefully, and get more and more consolidated care with same-day testing. And then the research arm is also helping us grow more, because we're not just, let's say, as Mary said, like we're getting them the IL-1 even before they see us. We're getting all the paperwork ready if they need to or not. But sometimes, you know, the nurse coordinator is going to go through the chart and feels like maybe they're a good candidate for this trial or that trial. So we started with the clinical stuff, the clinical demand, building the infrastructure and the workflow, and just basically seeking clinical excellence. And then the second stage, as we did the medical and surgical arms and the imaging arms, is the research arm. And and then it grows after that automatically and organically. And it has been really a rewarding experience. And with that comes support from, whether financially and funding from our institution for different roles, whether PharmD or APP, dedicated to the pericardial clinic, and so on. And we still have more needs. But that's kind of
yeah, great, Mohammed. Your center has really grown. So now I know where to send my difficult patients to, back to Chicago, as we know. Okay, so Jessica, so give us a little summary how you view this.
Yeah, echo everything that he said. I completely agree. We're fairly newer. So other things that I can offer as far as like considerations and challenges. I think at academic medical centers, one of the most challenging things we've run into is the turnover of staff and learners. So we will educate a certain fellow class on pericarditis, and then a new fellow class comes in, or our emergency department colleagues or internal medicine residents, and it feels like a perpetual need to educate. And so what we've done is sort of streamlined that. We've created PowerPoints and slides that we plan to do every year. We also have created order sets within Epic, which is our electronic health record user system. And we've created systems where all you have to do is type in a specific order set, and all the baseline labs for, you know, prior to starting rilonacept comes up. You don't have to dig through all the types of labs to get, and this just really streamlines the process, because we need those correct labs, we need the correct imaging at baseline. And so streamlining the process to make it user friendly for anybody that gets involved, be it in your core team or outlier teams, has been really helpful.
Terrific. And now Tom or Mary, what do you think in terms of organizing a center, some of the challenges? Let's say, well, we have a more mature center at Cleveland Clinic. What are some of the challenges out there?
Yeah, and so really there's a large volume of patients that need to be seen on a urgent basis. So really, what Mary has really done well with us is to help triage patients in terms of how urgent referrals or patients from different centers and who come to see us need to be seen, the order they need to be seen. Each of the pericardial center doctors have slots in their week of clinic weeks that are dedicated to seeing pericardial patients, so they can be added on to those slots, whether new or established patients. And already an open door collegiality, teamwork to work with is very important, where we have tricky cases, we can just go down the corridor, discuss with our colleagues. We can go on the phone and call our surgical colleagues, our rheumatology colleagues, to get their insights and input into this. I know some other centers have multidisciplinary teams, and we work with other centers as well, where other centers, cardiologists email us, call us and we can discuss cases and provide advice with them as well. So I think this sort of collegiality, it's a small community within cardiology, but we've worked well together with Northwestern, with Mayo Clinic, with all these other hospitals to managing these often complicated patients.
So Mary, what's the role of the APP? So we heard your presentation, but I should mention it took me many years to get somebody like Mary to help organize this. There's a tremendous amount of MyChart messages. Jessica mentioned the Epic. Every new patient does generate many queries about their medicine. So Mary, maybe tell us a little bit more about the role of APP.
Yeah, thanks, Dr. Glenn. I want to thank Dr. Glenn and Dr. Wang. It was a steep learning curve coming into this center. Learned a lot in the last 2 years, but I think the role the APP can especially highlight it in the accessibility that patients can have, the pericardial patients can have, because You know, if they can't, if it's a inpatient and they can't see a special, you know, they can't see Dr. Klein or Dr. Wang, so they're out or their clinic's full, they'll reach out, you know, they'll reach out to one of us and we'll make sure to get that patient in, you know, work with our admin staff and get the correct imaging for the patient. I think the APP really can help with the follow-up too. I think that's a major role that we play in monitoring the labs. If the patient's escalation, you know, needs an escalation of therapy, if the patient is having a flare, we really try to avoid them going to the local emergency room where they might put them on steroids, and it kind of just derails, you know, our therapy and our goal of therapy. So I think that is a big role that the APP plays in avoiding ED visits and just providing the patient support, education. Even if we, you know, a lot of times we'll get a MyChart message and a patient's having a flare, if we can get labs right away, add them on for a virtual visit that day, guide them through that flare, escalate therapy as appropriate. I think that really improves our patient outcomes.
Well, definitely, and I think Jessica showed all the pain points for all these patients. They go to ER, rheumatology here and there, and before they get to the right provider. So it's very good to have all these clinics in place. In terms of lifestyle changes, there's a question about, these are often young people. They're, you know, in the prime of their life, they're exercising, they're active, and they get smitten with acute pericarditis, which becomes recurrent pericarditis because they haven't seen the right person. What do you tell these people? Exercise, diet, or any thoughts about? Everybody may have a different approach, but anybody can chime in.
Yeah, it's always one of the most difficult part of the encounter, talking to young people and telling them, as a cardiologist, I'm telling you to restrict vigorous exercise. Because, you know, many of them do it for physical and mental health purposes, and it can be a tough part of the conversation. However, thankfully, many of them are very motivated patients who really want to get better. And we hope, I describe it to them as having a knee injury after playing soccer. If you go to play soccer too soon, you're going to prolong the recovery and make the injury worse. It doesn't work always, the analogy for them, but it's definitely a hard part of the conversation. But we restrict vigorous exercise, and once controlled, we do gradual exercise regimen, as Mary kind of outlined, in terms of a gradual build up with heart rate goals. And they kind of, very good patient, they follow that regimen. And IL-1s have obviously liberated us and allowed patient to go back to exercise much faster than slow tapers of prednisone. But it is definitely a hard part of the conversation. Obviously they can still live their life and do, you know, regular things, but the vigorous exercise definitely could be a trigger for them. With the IL-1s or other things, they might be able to resume it faster, but some do have recurrences on IL-1, but a good portion of them we can get away with that therapy on board.
Okay, can you hear me? I can't hear you. Can you hear me?
I can hear you.
Okay, another question was about like an inpatient to an outpatient, somebody that has acute pericarditis. Who should see the patient in follow-up? Do all pericarditis specialists have to see acute pericarditis follow-ups? Can a general cardiologist manage these patients? So they come in sick, then you need some type of follow-up. Anybody can answer that?
Yeah, so I think acute pericarditis, you know, is much more common in the than recurrent pericarditis. And if we saw every single acute pericarditis in the pericardial center, we'll quickly run out of slots. So, you know, only about 1/3 or 15 to 30% of people get recurrent pericarditis. So we focus on these patients. But it's very critical, I think, for the general cardiologist to be comfortable with managing acute pericarditis, which means you need to be on 3 months of colchicine and then the tapering course of either NSAIDs or high-dose aspirin to complete that. Because a lot of primary care doctors, surgical doctors, others, they just give them colchicine for 2 weeks or NSAIDs for a week and be done with it. And this is where patients are more likely to get recurrence. So I think at a minimum for a general cardiologist to see acute pericarditis patients, they should see them after hospital discharge, maybe in the 6 weeks to 3 month mark towards the end of the therapy, to make sure they're doing well, that they're improving. And if things are getting worse, if it's not responding to first-line treatments, or they're having recurrences or incessant pericarditis, that's the time you should refer to a pericardial center of excellence, where we can take it from there and go with second-line options if as needed. Is Dr. Klein disappeared?
Yeah, I think he's logging in again. Yeah, completely agree with Dr. Wang. I would add also to help bridge that gap that he mentioned, because some of the ER doctors, they just prescribe a 2 week of ibuprofen and that's the end of it. We still struggle with this. We have trying to do more educational efforts, even our internal institution and the local affiliates. It has been a struggle, to be honest with you. But to Dr. Wang's point, the initial treatment for the acute pericarditis is super important to hopefully improve and decrease the chance of recurrence down the road. But it's unfortunately not always met.
Yeah. Any thoughts on this, Jessica or Mary?
Yeah, we've actually ended up reaching out to our outpatient community pharmacies as well as our emergency room pharmacy colleagues to help with this education. They seem to be a consistent role in this, and making sure that patients present to the pharmacy with NSAIDs and colchicine. This could be pericarditis. Don't just say, oh, you could just go pick the ibuprofen up over the counter. You don't need a prescription for this. And then if they do that, the taper instructions are lost. And so I think involving the community outreach pharmacists as well as your emergency department pharmacists, if those exist, could be helpful players in, education.
One thing, sorry, my audio went out, but one thing I should mention, some big news in the pericardial space. Dr. Wang and myself and others have been involved with a document from ACC. There's a concise clinical guidance document that should be released probably within the next month, so stay tuned. There'll be a press release about this. This is big because this is the first time ACC and AHA have done a recent guidance document. We're hoping for a much bigger guideline from ACC and AHA. And the Europeans are releasing their guideline at the ESC meeting in Madrid, Spain this summer. So on myocarditis, pericarditis, linking both myocarditis and pericarditis. A question would be maybe to Jessica. There are studies showing the massive increased use of biologics. Are we ready for this? Are we ready for a lot of recurrent pericarditis, avoiding the steroids and going to the biologics and handling the all the calls and the, maybe 2 years worth of biologics and figuring out how to taper it or stop it or what to do with that? Any thoughts about handling the big influx of the meds?
Yeah, I think that has actually been one of the biggest challenges at our center. So I think having a robust pharmacy support, a pharmacy technician, I would recommend a pharmacy tech too, someone who specializes in prior authorizations and things like that to help expedite the process, not only for access, but then also potentially follow-up. We have nursing that also supports this, but at our institution, I'm the one following up labs, vaccines for the most part right now. I think we're ready for it. I think each center is different. We already have a robust specialty pharmacy with many biologics. And so I think, every center dependent, but that is what would make a center of excellence is access to a specialty pharmacy that already has experience with dispensing these agents, monitoring these agents, getting access to these agents.
Okay, we don't have too much time left, but let me finalize one good question for the whole group. The future, 5 years from now, just a rapid fire answer. What do you see the diagnostics and what do you see the therapeutics for this recurrent patient population? Mohammed, you start with you.
Yeah, just to be quick, I would say diagnostics, shorter time on MRIs, which has been evolving in the radiology world and cardiology world, which give us more access to MRIs and diagnostics, improving in terms of the quality and sensitivity. And therapeutics, probably oral agents that are, safe and effective with shorter, hopefully, duration of therapy. But we'll see.
Okay, Jessica?
I agree with what you said. Shorter duration of injectables and a better idea of transition to oral therapy that maybe has less immune suppression, less side effects in general.
Tom?
Yeah, and echo both Dr. Al-Kazaz and Jessica's comments about, with ongoing clinical trials, hopefully we'll have more selection of therapy choices to tailor to patients' needs, and hopefully more sort of disease modifying medications that can, shorten the course of treatment, and people can come off medications will not have flares coming back on, rather than just disease, suppressing treatments that can, better treat these patients and prevent recurrences altogether.
Mary, the future, are we going to have too many patients coming to the Cleveland Clinic, or are we sending them to Utah or to Chicago?
Never too many.
Our hope is that we have more pericardial centers that patients can access, and providers like more pharmacy tech, doctors of pharmacy, APPs that can manage these patients.
Yeah, I'm not worried about the patient volume because, it's like amyloid. When I was a resident, like amyloid was this rare thing that's like, you diagnose. Now amyloid is left and right. Same thing with recurrent pericarditis. The more you have advances in imaging diagnostically, or otherwise, the more advances you have in therapeutics, patient will be diagnosed better, faster, and have access to those patients. And it's good. The good thing about the pericardial group from Dr. Klein, Wang, Dr. Kremer in our center, everyone else is they're collaborative, and it's a close community. So it's a great opportunity to work across this group.
Okay, with that, I think we have to close 1 o'clock. I want to thank the all-star cast of pericardial specialists across the country, and thank the AHA for supporting this fine program. Thank you so much, and I'll turn it over to Bianca.
Thank you, Dr. Klein, and thank you to all our panelist speakers for today's webinar. As a reminder, this webinar is a part of the AHA Addressing Recurrent Pericarditis initiative. Again, we want to thank you, our audience, for participating in today's event, as well as our panel speakers. After today's event, you will receive a follow-up email with a survey on the presentation, and we would appreciate your completion of the survey and your feedback. In that email, you'll also receive a link to view a recording of today's presentation. On behalf of the American Heart Association, thank you for joining us and have a great day. This concludes today's presentation.
Thank you.
Thank you.
Thank you.